So while Odessa is from Kenya, I think this topic is very global. um, and I think some of you know Odessa already. Odessa recently joined ISA board as a board member. We're absolutely delighted to have her. And she is a nurse, a nurse educator in the neonatal ward in Kenyatta Regional Hospital. So, Odessa, I am going to hand over to you. You can say anything else about yourself that you like, and then just launch into your presentation. And we'll let Odessa talk through her presentation, and then we'll have a bit of a discussion afterwards. So, Odessa, over to you. Thank you.
Thank you. Thank you so much, Paula. I think you've done a good job with the introduction. Well, my name again is Odessa Omanyo. I am based in Nairobi, Kenya. I'm in the largest referral facility in Kenya, so that is Kenyatta National Hospital. I work as a neonatal nurse and a clinical instructor. So I have been practicing as a neonatal nurse since 2016. Yeah, thank you. So maybe we can start. Today we're going to be talking about emotional reality of stillbirth. So that is from my own perspective as a neonatal nurse and a neonatal clinical instructor. We are going to be talking about my background. So I give you a bit of what I do so that some of you who are not medics can understand. I'll be focusing majorly on supporting grieving families, families who have been affected by stillbirths, so how we support them. And also I'll be giving you the Kenyan context, so where we are in terms of statistics of stillbirths, some of the causes or the leading causes of these stillbirths that affect most of our communities. Talk about some systemic challenges, that affect us or are leading causes to having us having the stillbirths and how they're affecting us emotionally. I'll give you two personal stories. So these are from people I know, a gentleman and a lady who are both nurse midwives. Also share about emotional burden on the nurses and midwives generally, and how they cope with these challenges and what really needs to change so that we have better outcomes in our facilities and institutions. Okay. So most of the days, this is where you'll find me. I am the lady in navy blue with a pink stethoscope. I'm surrounded by my students. So these are neonatal students in the NICU. Our NICU is we have a 7-bed capacity, though they are split in two. So that is where we are at the moment. Our students usually rotate in the NICU. They also go to the labor ward where they gain experience on how to monitor mothers who are high risk, also assist to stabilize babies. So basically, that is the picture you'll see me or you'll find me in my daily life. So a bit of my background, well, my main aim is to bridge practice and theory. So as I said, our students usually have a theory session, like 10 weeks, then they go to their clinical areas for 3 months where they gain the skills. So I am the link between the school and the hospital. So what I do is I monitor high risk. I teach students to know how to monitor high risk newborns. So these are babies who will come from mothers that had either hypertensive disorders, had diabetes, mothers who are bleeding during labor. So these are skills that I ensure that our students gain so that they know how to take care of these babies. The other thing is I also teach neonatal resuscitation, so others understand it as Help Baby Breathe, the program. We help stabilize babies immediately they are born, so we help them breathe. And those ones who are maybe in the newborn unit, we ensure that their respiratory status is maintained, their fluid status is maintained. So basically just to help them survive. The other thing is I help them know how to support families through loss. So I teach them, or rather mentor them, to know how to work with these families, especially families who are looking at their babies who are very critical and they've been informed that their prognosis is not so good. So babies are going to die. So I teach them how to work with these families, at least to just, improve the outcomes of the family so that they're not really stressed out during this period. I also mentor them to have these empathetic skills, just to put themselves in the shoes of these families who are suffering loss, and also promote respectful and maternity care, teaching them to know that it is important to maintain the dignity of these families, offering them with compassionate information, just ensuring that they understand the whole process, because it's not an easy one for anyone. Yeah. Next, please.
Sorry, my computer seems to have stuck.
No problem.
1 second. If I can get it. There we go.
Okay, so I said I'll measure on this one, which is supporting grieving families. So what we do as neonatal nurses, as midwives, is to ensure that you are there for these families. You offer them a listening ear. Some of them are illiterate and do not understand medical jargon. So ensure that we break down this information to words or to sentences that they can actually understand, and just to feel that there's somebody there with me. As much as it is difficult, there's somebody there with me who understands what is happening and who is helping me go through this journey. We also help families say goodbye. So I can give an example. In the labor ward, they have a room specifically for mothers who are to deliver stillborns. So once the baby is delivered, they give them time to bond with the baby. They dress the babies. They also help them name them. So we also have a chaplaincy where if they want the baby baptized, they also baptize their babies. So we just take part to help them say goodbyes, send their goodbyes to their angels. The other thing is to share honest and compassionate information. So we just make sure that they understand, so that we're not putting ourselves in a situation where now people are suing the institution because they didn't have the correct information, or people are cursing nurses because they felt that they're not really taking care of these babies who are very sick, or just giving them the clear picture of what is happening to their babies. We're not hiding anything, telling them that their babies will get well. Yet we know that their babies are not doing very well. So we just work with them and ensure that they understand the repercussions of everything that we are doing, and that they're not alone in the journey. So we also ensure that their spiritual and cultural needs are respected. That is, if they would want to have like a mass or a service for their babies, if they're Christians, that is, we give them the chance to just have that time with their baby and the chaplaincy, so that they feel that everyone is incorporated in all they want them to do. Yeah. Next, please. So I'll give you the Kenyan context and just explain where we are as a country. So we are having approximately 35,000 stillbirths annually. That is according to WHO. And this equates to approximately 20 per 1,000 total births. So total births here are live births and stillbirths in total. That's a huge, huge number. And the leading causes to this are: one, we have obstructed or prolonged labor. So this mostly affects the primigravidas, the people who are just having their first pregnancies. Most of them don't really know what to do. Some of them did not even attend antenatal care, so they do not know how long labor should take. So when you talk about prolonged labor, here we are looking at labor that lasted more than 18 hours. So if they do not know that they were supposed to seek care, then they tend to fall into this category of losing their babies because they didn't know what to do. The other leading cause is hypertensive disorders. So mothers who are suffering from hypertension in pregnancy or even during labor tend to have terrible outcomes, especially if the team is not equipped either with equipment or knowledge on how to handle this type of delivery. We have infections. There are parts of our countries that have that are known for endemic infections like malaria, like the coastal region, the western region of our country. It is malaria is just endemic there, and it's a problem because it really affects on the blood supply to the baby. We also have syphilis. We have conditions like HIV. People not adhering to the ARVs or the antiretroviral therapy that they're being given, or some of them just don't do antenatal care. So they tend to really risk the lives of their fetus. The other thing is poor monitoring of labor, using of the partograph, proper use of the partograph tool used to monitor labor. So sometimes it's because they are overstretched. So you find a single midwife having 4 mothers to monitor. 2 of them are delivering at the same time. So getting time to even monitor the other 2 is a total problem. So some of these reasons are actually causes of why we are having this high stillbirth rate. The other thing is referral and decision delays. So here we are talking about delay in seeking care. So they decide to labor at home, not go to facilities. And when things get bad now, that is when they decide to rush to a facility. They do not have the money to transport or for transport or to get to the facility. The other thing is delay in receiving that care, that quality care in a facility. So there are a lot of things, a lot of delays that actually attribute to this high stillbirth rate. I got an opportunity to work in a facility before I went to Kenyatta. It was a nursing home, and I realized that some communities have a specific person to make decisions. So the lady that I was handling had non-reassuring fetal status, and it was the next of kin to make the decision that the mother was supposed to be taken for cesarean section. So the husband, who was the next of kin, was in America. I remember it was around 4 p.m. So in America, I think it was like 1 p.m., 1 a.m. So they really tried to get hold of this person on phone so that they give the go ahead. So fortunately, they did get the person, but that really put us in a position of, are we supposed now to refer the mother because the decision is not being made on time? So such delays can really cause or can really lead to an increase in this stillbirth rates, which we're really, really trying to prevent. Yeah, thank you. Next. So some of the systemic challenges that we are facing are this one is understaffing. Understaffing cannot be overemphasized, and burnout. So having a single staff managing very critical babies or managing mothers who require close observation is not fair. Is not fair to the individual, is not fair to the system, is not fair to the society. So this really brings a toll to the individual who is managing these mothers, because what if they have bad outcomes? Now, is it for the staff who didn't manage the patient well, or is it the system? We are put in a fix. And the other thing is weak referral systems. So we have facilities that are running with ambulances that do not have fuel. And it is totally up to the family to raise the amount to buy the fuel so that the ambulance can take the mother in labor to a higher level facility. So, for example, if it's from a health center, you need to raise the money to buy fuel to take the mother to a, for example, a level 3 or a level 4 where they can do cesarean sections. The other thing is equipment and drug shortages. So you are working in a system where they do not have working radiant warmers, or they lack drugs, or they lack, functioning suction machines. So this really poses a risk to the baby that you're trying to help deliver, or even to the mother herself. The other thing is limited antenatal care follow-up. So you are genuinely, you are faithfully attending antenatal care, but this place cannot even help you get, for example, an ultrasound. So all they do is listen to the fetal heart, give you probably supplements, and allow you to go home. But you won't really get the picture of how your baby is developing. So such things are really causing a toll onto the medical staff that are doing their best to get better outcomes of these families or of these babies. So I decided to do a very informal interview. So this one was, I honestly did convenient sampling. So I just went direct and talked to a friend of mine. This is a male midwife who works in labor ward. And I just wanted to get his perspective on how managing a stillborn or a stillbirth is affecting either his family or anyone or his friends. I just wanted to know how does this really affect them emotionally. And he had this to share with me, so he gave me a short story. And maybe if you'd allow me to read it. So he said, I have had several experiences working as a midwife in the labor ward over the past 5 years. So I think the one that touched my heart is my colleague's story. So he started by sharing this colleague's story, who is his friend. So she had lost 2 precious pregnancies. It has been difficult for her because her in-laws were now demanding for a child. So they do not understand that due to various gynecological issues, she has not yet managed to carry a pregnancy to term. So being a medic and understanding her condition inside out and still working in the labor ward hasn't made it easier for her. So he continued by saying a few months ago, she requested to be transferred to a gynecological ward, as she could not stand helping mothers deliver their babies, yet she could not hold one of her own. We used to share a lot, especially during her low moments. I believe it's only God who can grant her her heart's desires. So you can imagine not having a baby, or you having two lost pregnancies and still expected to work in an environment that has high stillbirth rates is not something that you'd wish for anyone, because it's like mental torture. You have to escape this environment for you to feel stabilized, or for you to maintain your mental health. So that honestly I felt for this lady. As much as I don't know her, I felt for her because you have to switch your environment to feel better. That was a sad one. So as I was taking this, as I was conducting the interview, another lady popped into the room, and she was curious to understand what we were doing, what we were talking about. So she got in and decided to also share her story. It was, I don't want to say I was lucky, but I felt bad, but it was timely. She shared her story as well. And she started by telling me that in 2020, so this is her, I've quoted her words. So in 2020, I lost my pregnancy. I was 32 weeks when it happened. I was in the house when I saw a gush of blood. I think it's because I overworked during that time. So at this time, she was referring to a moment where we had a huge county strike, hospital strike, and most of the facilities were transferring their patients to Kenyatta National Hospital. So she continued and she said, we were overstretched. I think I stood for too long. I think I stood for too long that day and went home very tired. My husband rushed me to the hospital, but it was too late. My baby was 1.5 kilos. That translates to 3.3 pounds. It was devastating. She took a long pause and she started crying. So we had to slow it down. Then she continued and she said, the other week, I, I monitored labor of a lady who had a macerated stillbirth. Her husband accompanied her. Her baby weighed 5.4 kilos, which translates to 11.9 pounds. Gosh, I cannot forget how heavy the baby felt in my arms, like a 2-month-old baby. It was difficult for her to show the father the lifeless baby. So I almost teared up in front of them. Memories of losing my baby came flashing into my mind. It was then that I realized I hadn't healed. This was so sad. Keeping in mind that this is a lady who has not changed her station, is still willing to work there. And it's not promised that we'll never have any other stillbirth to be conducted. But this is the same person who will be holding these babies, showing these families the babies, and always being triggered by this stillborns that she's holding and showing these families. I honestly really felt for this lady, but she's positive and really resilient. So I have a harsh reality here to share. So in May 2025, our facility, Kenyatta National Hospital, put out a public notice of unclaimed bodies in the facility. So those are bodies in the mortuary. There was 260 of them. So due to my curiosity, I wanted to see who are these majority? And to my surprise, 122 of these bodies were actually stillborns. That shook me. I was like, why 122? It is truly an emotional crisis because now I was thinking of this lady who just shared her story. What if she has delivered majority of them? Okay, I didn't go back and ask her how many she has delivered, but it was just in my mind. What if she has delivered majority of these babies? What are we doing to her mental status? What are we doing to others who I didn't get an opportunity to actually just interview and hear their stories? So I do not know why they did claim these babies. Probably it's cultural. Probably it's economical. They don't have a place to bury them. Probably it's, they do not want, it's the stigma that is behind them. They don't want people to know that their baby didn't survive. But we will not forget the torture that also the healthcare workers go through when they deliver or assist in delivering these mothers. Honestly, this is terrible. So we go on to the the emotional burden that these nurses carry. So witnessing loss despite best efforts, these nurses do a lot, especially times when you're having medical strikes. So medical workers are not working. They have hundreds and hundreds of mothers coming to sort for help. It is still the few people that are in the labor ward that are expected to help deliver these babies. And unfortunately, most of them die. So it's really, really sad and it's burdening if you think of it. Feelings of helplessness and grief. So you can imagine you're doing your best and you lose a baby. At times you even lose the mother and you feel that you can't do it anymore. So you go home and you have a family that also waits for you. So I feel that circle is not healthy. Having to try and do your best and nothing comes out of it is not motivating. It's actually discouraging. The other thing is balancing professionalism with personal sorrow, just like the story I've given. You can imagine the family expects you to be composed. The family expects you to be in a position to give information, yet you're broken inside. So this is truly a burden to these people or to the nurses and midwives working there. Then we don't have formal support systems. You lack places to even debrief. What did you feel after this? What did you see? What did you learn? So we don't have spaces for this. And this might be torture because you're expected to appear tomorrow and continue with whatever you're supposed to do. So this is torture to them. So what do they do? What do we do to cope with such emotions or to cope with such happenings? So we try to have peer support and informal debrief. So like the example I gave for the gentleman, he says he usually shared with the lady, especially when the times that she felt low. So she's lucky she has someone to talk to, but this doesn't apply to everyone. And I feel that it is important for each one of us to like provide the support, especially when one feels drained emotionally, physically, just to air out your feelings so that you get that stability. Paula, please move to the next slide. The other thing is creating strong teamwork and culture. So working as a team, even if you are short-staffed, it's quite it can be consoling, knowing that yes, we are going to share gains and also we're going to be sharing these losses so that you don't feel you're not totally blaming yourself for a bad outcome because you had a team that was giving it its best. So that is the other way we cope with this. The other thing is prayer, spirituality. Those ones this basically are for believers, people who believe that they regain their strength from the Lord. So praying a lot, believing, and also having reflective journaling. So sitting down and just writing your experiences of the day, what you faced, what you feel you can do better. This is really helpful, and especially I encourage my students to do this as well. The reflective journaling really helps. And the other thing is family support. Well, if you're lucky to have family, then you just go back and share your experiences. They help you vent. If you don't have close colleagues, then you go to your family and you just vent, explain what really made you feel bad, what you think, what you feel that rather you can ask them, what do you think I'd do better? Or they even give you your strengths, remind you of your strengths. So that builds resilience in staff who are working under hard conditions. So what I do, again, as a clinical instructor is teach through emotional reality. So not so far back, we never used to have a state where we can say our facility is full. So we were receiving patients as they come, we admit. So we were never full. That is what we usually joke about, that Kenyatta is never full. But we are lucky our cabinet secretary for health uh, put it out that now we're just admitting one patient for one bed. So we teach students that even if we have a lot of patients, even if you feel outstretched, please note that it is up to you to ensure that these families don't feel alone. So we actually tell them the truth that you will not be in a facility where you will not be in a state where you feel that you can just have this one client and give five-star treatment. No, you will have overflowing patients, and this is how you're expected to behave, or this is how you're expected to support these families. The other thing is modeling empathy and presence. So I ensure that our students observe me counsel these families, observe me share health messages, observe me being there for this mother who has probably a bad obstetric history, and now we are trying to work with her. So they actually see, so that they can see it is possible to actually just be there, cry with them. It's normal. It's nothing, it's not a taboo to cry with a stranger. No, they're human. So we try to help them understand that this is actually normal. It's fine to cry with parents. It's fine to cry with patients. It's fine. It's okay to be there with them. So by telling them that it's okay, we are trying to build resilience in them. We are trying to ensure that they can also mentor others, not just being students there, because they'll eventually graduate and will now be supervising others. So it's okay we are just telling them that it's fine to cry, it's fine to work with these families, and hoping that they will eventually reflect this to the rest. So the other thing is creating a safe emotional space in training. So not only do we have simulation labs where they have scenarios where they help to manage grief, we also give them space, even in the clinical setting, to just come and break down in front of you and you support them, because sometimes they feel overwhelmed because of things they also go through as individuals. Some of them are parents, some of them are parents to be. And when they observe that things are tough, so you come and you sit down, allow them to cry, allow them just listening, giving them that listening ear. I feel that it really helps, because they also believe that, okay, we are human, and they trust that if somebody stood with me, then I am competent enough also to stand with somebody else, so that I ensure that I give what do we call it? I give support to these families that are grieving. The other thing is just teaching them on how to cope. Again, I said reflective journaling, taking deep breaths, taking a walk. This really helps them to calm down emotionally so that they can appear the following day. Yeah. Next, Paula. So what do we need to change? We need to improve staffing. If staffing cannot be improved, if we're having managers in this call, if staffing cannot be improved, then ensure that we have equipments that are working, ensure that we have drugs for this patient. At least that is motivating. Because if we look at the number of nurses that are leaving the country, number of nurses that are retiring, unfortunately, the number of nurses that are dying, when you look at the balance, it doesn't match up. So if anything, we start small. Please provide the essentials that we need to work in these hard times. The other thing is building emotional resilience in staff. We really need to tell them that it is okay to cry with strangers. It is okay because we are human. That really builds resilience. Including emotional debrief in care systems. We do not have this. We do not practice this. If it is done, then it is very minimal, because it's a new concept for most of our facilities. So we need to ensure that people share their feelings, especially during bad outcomes. A patient has died, a baby has died, even despite best efforts. We need to show them that it is okay to share. The other thing is include bereavement and support and communication training in our syllabus, in our curriculum. This is lacking, and if it is there, it is a very small unit. So it is important for educators, for managers, to ensure that their staff are trained on this. This is imperative. This is paramount. Last but not least is offer the safe spaces for staff to express emotion. Just the same way I said, debriefing is key. People need to express their emotions so that they're not burnt out. So in conclusion, what am I saying? That stillbirth is more than a clinical outcome. It is a deeply personal tragedy that leaves lasting emotional scars. Please be kind to families. Please be kind to health personnel. There are individuals that are going through a lot. Nurses carry this silent burden and they do not speak out about it. It is killing them inside. And some of them are thinking of moving out because they can't do it anymore. So we are saying healing requires compassion. Healing requires you and me. Healing requires the community. Healing requires this systemic change. Let's care for these families. Let's care for these health personnel. Thank you very much for listening. That is my email address. Where to find me is at KNH. Please become an ISA member if you want to be part of the community that moves mountain, part of the community that wants us to prevent neonatal deaths, prevent stillbirths, and ensure that parents have this respectful bereavement care. This is the place to be. Thank you very much.
Oh, thank you so much, Odessa. That was fantastic. Really, really moving and very, very personal from you as well. So really appreciate that. Thank you so much. We're going to open it up for any questions or discussion or comments, or if you want to share your own experiences, anything at all, please do feel free to just unmute yourself and speak up. I'm sure there are other frontline health workers on here who might have similar experiences. I just want to say that I started off in hospital care as a doctor in a neonatal unit after I'd done my intern year. And honestly, it was the most stressful year of my life, probably. Because as you say, you're confronted with death quite often, and you're confronted with very vulnerable mothers and babies, and that is extremely stressful. And it's much more stressful for the nurses and midwives because you are spending much more time with the patients, the mothers and the babies, than the doctors are. The doctors are kind of coming and going much more. So I have so much admiration for nurses and midwives who work in labor wards and in neonatal units. I think it's such a very, you have to be really dedicated. And Kenyatta Hospital is very lucky to have you, Odessa, because it sounds like you are an amazing clinical instructor and giving fantastic support to nurses and midwives. So would anybody like to make a comment or ask a question? Please just unmute yourself and go ahead. We're seeing some comments in
Hello.
the chat. Go ahead.
Yeah. Hello. Yeah.
Hi, Neil.
Yeah. I'm Neelam Agarwal from India. Excellent presentation, Odessa. I really congratulate you on your good work. So
Thank
I am a obstetrician. I am also a clinical person. Always means day in and day out dealing with these losses. So just today only, I met a friend of mine who had lost her son 20 years back. But still, when I met her today, means I was myself again emotional. So means how to heal ourselves. Can you just give some suggestions how to heal ourselves? Sometimes we become too personally involved with somebody, right?
Mhm. I think, Nimal, I think death remains with us. I think we cannot pull it out. You cannot ignore that.
Yeah, because what I was
Sorry?
feeling, why I got emotional again means because we were all together, everything together means our husbands were friends and colleagues, and we were colleagues, and then means maybe it's a sort of guilt that I am having my normal children, she's not having her child. I don't know. Means how to overcome this guilt.
Do we ever overcome death? Do we ever overcome the feeling of losing somebody who is close to us?
Yeah,
Personally, I don't think so. Personally, I don't think so. Because every time you meet, she reminds you, that thought of her not able to get children, you having your
yeah,
own, it's like there's no
yeah,
balance. This life never gives us a balance that we are looking for. It is just for us to be kind to each other, not telling them, okay, it's okay. No, no, no. We're just saying that I'm here with you. Anytime you feel like sharing, I'm here for you. Okay? That is personally what I do. Let's share. Let's talk about it. I'll never get tired of listening to it. Maybe that might help soothe whatever they're feeling. I don't know if you have any other point. Paula, you'd like to share?
Yeah, no, I totally agree with you, Odessa. It's just being there for people, isn't it? And we hear, we have a lot of bereaved parents who are members of ISA, and we hear this all the time, that pain, it might diminish somewhat over time, but it never goes away. And every anniversary or every, memory that is triggered by a certain event, or a friend having a baby or another death or whatever, can set people off again. Of course it does. It's because, the death of a baby especially is just so traumatic, and so it should be a time of immense happiness, and you're expecting a new baby and everybody's excited, and then when you lose the baby, whether it's a stillborn or born, as a new dying as a newborn, it's incredibly traumatic, and that never really goes, and people, do carry that burden with them for life. I think you're right, absolutely right. All we can do is be there for those people, and to, give a listening ear, a helping hand where we can, and just be there for each other. Thank you, Neelam, for sharing. It's a tough one. I don't think anybody has the perfect answer. It's a
Yeah,
hard one.
I
We've
know. Just
got to
yeah,
be
the
there
same
for
thing
each
as
other.
you said. Sharing with each other means that lessens your guilt and you makes you
Yeah.
strong. Yeah.
But I think our really important point today, is which we don't often talk about, is the health worker experience. We focus a lot on the parents, and that's absolutely right. Of course, we have to focus on the parents, but we sometimes forget about how much the health workers take in themselves and how much they're dealing
Yeah.
with. And if
Yeah.
you don't have good policies in place in health facilities to help staff manage that, and if you don't have a good home situation where you can get support at home, that makes it really difficult for our health workers around the world, and especially in those high burden settings where you're seeing many deaths maybe every month. It's very traumatic. Yeah, absolutely.
Yeah.
But I think we also have to look on the positive side. You gave some excellent coping strategies, and I think that's really important to take forward. And how can we as a community, you know, work together to ensure that those practices and policies are in place around the world, so that health workers don't have to bear such a heavy burden, that it can be eased, and that we have systems in place to help them. You mentioned lots of things. And I have to say, coming from a higher income country, where I come from Ireland, although I'm not based there at the moment, but a lot of our nursing staff in Ireland are not Irish. They're coming from the global south. They're coming from African countries. They're coming from the Philippines. They're coming from India. At least a quarter of our workforce is from overseas. We are part of the problem. We are draining health workers from countries that so desperately need them, much more than we do. And we're selfishly taking those health workers into our systems, because, every country wants to look after itself, but we don't look at the consequences of that for those countries which those health workers are leaving, and we are leaving those health systems even more bereft of qualified workers. It's really a shame. And I think, the global compacts and things, we haven't tackled this well enough to, say that uh, we have to have a system that is fair. If we are trying to attract workers from lower income settings, which of course is attractive for them, they might get a higher salary and a better working space. But what are we doing for that country in exchange? We are leaving it worse off, and that is not fair, and it's not right. And I think as a global community, we also have to advocate for that. But I'd love to hear from other people. Anybody else have any comments? Rose, please.
Yeah,
Go ahead.
yeah. Hello?
Just one sec, Adolf.
Yeah,
You're
this
next.
is Adolf.
Okay. Go ahead, since you're unmuted, and then we'll have
Yeah,
Rose.
it's okay.
Go ahead.
Okay, thank you. Thank you so much.
No
This
worries.
is Adolf. I'm Obigain from Rwanda. So I really appreciate about the presentation Odessa did, and it's very interesting. So I am wondering, maybe Odessa might not have the response to questions, but stillbirth is really a burden. And as you mentioned somewhere, where there was many cases about obstructed labor, delayed transfer. Those were some of the cause in your context, which is not different from our, but there is some, of course, case which happen for stillbirth and early neonatal death, where be somehow avoidable, if I can say on that way, because of shortage of staff that to monitor labor of maybe 10, 20 women, while you have like 4 midwives in monitoring those women. Sometimes they might be some case of obstructed labor or non-reassuring in the fetal status, which are not diagnosed or seen on time, which can end up with stillbirth. So, can we have to think about any maybe solution to advocate for those cases, and maybe to call upon the government how they can increase the workforce, health professionals, maybe to in order to reduce the stillbirth, for in case where it can be possible. I don't know. That's somehow complicated, but possible to.
Thanks, Adolphe. Odessa, you want to take a shot, or do you want? Go ahead.
Yeah, I think I can just repeat what I said. We were lucky enough just a few weeks ago, our cabinet secretary actually just said now that it is 1 patient, 1 bed. There used to be 3 patients in a bed. We used to have 4 babies in an incubator. We still have, because we're trying to lower the numbers and no more. We are no longer admitting more babies, but that was our state. So we are lucky that we are heading into the right direction. I am hopeful that Dr. Adolphe, you will follow suit. Your government will follow suit.
Yes, hopefully. It is absolutely,
Sure.
it's a case of investment, isn't it? It takes funding, and it takes political commitment to make sure that funding is available to train enough health workers, to make sure that they have the right equipment and supplies and drugs, etc., to do the job that they are supposed to do. And that is woefully lacking in too many places. I hope that Rwanda is not too bad, because I think you have actually invested quite a lot in your health system. I think you're doing relatively well, but I'm sure there's still a long way to go, as there are in most places in the world. But I'd like to give Rose a chance, because Rose, you had your hand up. Please, can you unmute yourself?
Thank you so very much for the great presentation, and also for the opportunity to just give 2 comments. I do listen to the Odessa. I'm a midwife working in Kenya, and I have had the opportunity of being with women and also being with my colleagues in these instances. And the most, the one I think about when I think about myself and my experiences is when I have to continue with my duty even after I have conducted the delivery, and the woman has a stillbirth, and maybe they are sharing the cubicle, and I have to hand over the stillbirth, and in the next bed I continue to congratulate another one who has had a live birth, and another one, and maybe the same day I have to conduct maybe 3, 5 live births, and yet the emotions I had with the stillbirth are still with me. And I don't know how to deal with that. And I still have to go and talk to this woman. And also balance, that's what Odessa was talking, what balance do we have as healthcare providers within our emotions to deal with these situations? The second comment is concerning the stillbirths, or women who come with stillbirths already with an ultrasound in labor ward, already it has happened. We don't have the causes, the normal causes that we know, the obstetric labor. We don't know actually. We don't know the reason. And here we have this mother deliver and then be given, discharge. What follow-up? What mechanisms do we want to see following up these women? Maybe investigate the maternal and follow up future pregnancies, because we have in cases of women coming with 1 or 3 consecutive stillbirths, because our systems do not allow us to have these women investigated in cases where the stillbirth happened and we actually don't have the direct causes that Odessa actually mentioned. Those are the 2 comments, but I think the strategies that you have given us, I think I'll also look at them and also be able to practice them in my future workspaces and also help my colleagues. And as a teacher also see how I can incorporate most of these things in my daily teaching, and also making it very, like our students to actually have this concept beforehand, before they go face these dilemmas and become what we are, because we actually in the middle of a balance, which we cannot really say that we can be able to cope with. Thank you.
Thank you so much, Rose. And it's such great points. You're so right. We need to prepare people in advance, and that goes for parents as well as health workers. Many parents say to us afterwards that I'd never even heard of the word stillbirth. I didn't know it was a possibility that I would lose my baby. So, while it's very difficult to talk about that, especially during pregnancy, it's really important, because people really regret it, and they're angry about it afterwards, that they had no idea. And so without wanting to scare people, we need to make them aware that there are possibilities that things can go wrong. And exactly the same with health workers. We absolutely need to help them better prepare. That's something that ISI has on our agenda to do, but we've got 2 hands up. So over to Linda first, and then Zala. Linda, please.
Thank you very much. A very important presentation. And I agree totally with you, Odessa, in terms of what should be done for the staff. I think that it's important before students come that they also have probably a short meeting with a clinical psychologist if the person is available, and people like you who are tutors, to prepare their minds for this. I remember many years ago when I was in medical school, a student nurse was asked to attend to a person who had died, and this lady just broke down and started crying. So the head of the unit had to take over. And I think it was because this girl was not prepared to see death like that. And as you said, it's something that is real. And so we have to prepare them. The other thing which is sad is the number of 150, you said, of the number that were stillborn. I think that this gives us the opportunity to do more to prevent stillbirths. When I was in the children's ward, it was so sad to see babies carried every day because they were dying. It's such a sad thing, and it doesn't go away, as you said. So I think there's a lot that can be done, and it should start from the training institutions, not just for the nurses, but also for the medical students, and all other health providers in training should be aware that this happens. And I think that will go a very long way to address some of these. Thank you very much.
Thank you, Linda. Absolutely right. We need to start at the beginning, don't we? Zala, please. Zala Munir.
Hello to everyone, and thank you for the great presentation. So I want to share my experience as a OBGYN trainee in Afghanistan. So I listened to this lecture, and it reminded me the days I was working in the hospital, and one thing that made me so sad, that in Afghanistan we do not have such thing in the name of mental health support, neither for the students, for the doctors, or like the patients. They do not know even what is mental health. So how can we support them? How can we, like, even as a doctor, when you cannot like when you yourself do not know about the topic, so how can you support or like give support to the patients? So I was working in a hospital, which is one of the most crowded hospitals in the capital. So and we had more than like 20 C-section in one day, or more than 50 deliveries in one day, or like more than 200 IPD OPDs and 100 IPDs in one day. So sometimes I feel like we like it was not fair for the patients, at the same time for the healthcare providers. So like we had one doctor for like 50 deliveries, or we had four doctors like with for 24 hours for more than 20 C-sections in the like the operating room. And or like the ward, like the hardest ward, we just had two doctors. So you can imagine how was the status of the patients, and in meantime the status of the doctors who are working for the patients. So sometimes I feel like it is just the god who is saving both the healthcare providers and the patients in that country. So I just worked there for 3 years and left it for the overtake of Taliban. But now, like when I hear back about the country, and when I just remember the situation there, it makes me so sad, and it makes me that how like the situation there is like. I think about my colleagues, I think about the patients, and I sometimes I pray that if I had the chance to go back there, and if I can do anything for the patient or for my colleagues, I and at least I will like do something to make them aware that there is something by the name of mental health. There is something that you have to take care of yourself. In the meantime, you have to take care of the mental health of the patients. So yeah, yeah, like it's so hard. It's so hard to be there. Like when you are there, you do everything to like do good for the patients, but at the same time when you feel like there is nothing for yourself also. So there is like when I'm in the US right now, and when I see this facilities there, I pray that I wish we had even one person there in Afghanistan. We work with the minimum, and we do the maximum for the patients. But it's not enough for that. It's not enough for the babies. It's not enough for a mom with that pain and that hope to have a child. But it's not sufficient for any of them. And I pray for that. Thank you for the listening.
Thank you, Zala. Thank you for sharing your story. And yes, we know things are really, really, really tough in Afghanistan, for women and girls and nurses and midwives. So we have two more hands up. So I do want to give everyone a chance to speak. Odessa, if you're okay for a couple more minutes.
Yes, sure. No problem.
Okay, great. Ashley, and then Edel Queen. Edel Queen. I hope I've said that right, Edel. Ashley, go ahead.
Hello, I hope
Hi.
you're all well. My apologies, I joined the conversation a bit late, but I'm very much interested to know, Odessa, are you doing the training here in Kenya?
Yes, I am. I'm in Nairobi at Kenyatta National Hospital.
The training happens in Kenyatta?
Yes, it does.
Okay, because we also, as an organization, we also have something similar that we've done on bereavement care training that's specifically catered to healthcare providers and administrators. And I would be very much interested to also learn from you. I think we can connect on that because one of the issues that also we experienced when we were training is that the emotional aspect of the healthcare provider. We had one who even said, I can't even think of conceiving because I'm too stressed to conceive. And we did a mental health test, and 75% of the attendees were actually struggling with their mental health. So I think this is something that is very, very important. We've actually received our second round of funding to do the training, and I'd be very much interested maybe to have a discussion further on this particular issue. Yes. So I will follow up with you.
Okay, Ashley, I'd love to work
Thank
with you.
Yeah, this is great, connecting our Kenyan members together. So Ashley, yes, and please do connect with Odessa, and we'd love to see you working together in Kenya. Two are always better than one, right? So the
Yes,
more you have, the merrier.
sure.
Edel Queen, is that the right way to say your name? You have your hand up. Please go ahead. Hi. You're still muted, Edel. Can you unmute yourself? Let me try and help you.
Yes, yes. Can you
Oh, there
hear
you
me?
go. Yes, got you.
Yes. Okay, Madam Odessa is actually my clinical instructor from
Ah.
Kenyatta National Hospital. And I can tell you she is the best of the best. She is guiding us through a journey that is tough in healthcare, but she is trying her best in holding our hand in each and every step. My concern is to state that it becomes very hard as a healthcare provider, especially after getting a delivery and you have to continue with work pretending that everything is okay and it is not okay. One thing, this has led to most nurses getting into depression, midwives having a deranged social life. Some of them don't want to get married. Some of them have minimal number of kids because of the detrimental torture that they see their patients going through. Some of them go into drugs, overdose, and even go to death. So stillbirth is something that has to be addressed in one way or another, and it's not okay. It's not okay to conduct a still delivery and act as if it is normal. We need the debriefing. We need to be held our hands. We need to be told it's okay to cry. After that, you don't have to act strong. Go out, cry it out. Look for someone who you can talk it out with, because it has even affected some of our social lives. We want to stay in isolation, asking ourselves, are we normal? After a stillbirth, I go wash my hands, go and continue eating as if it is a normal thing, not remembering that it is a life lost. So it is something that has grown in us, that having a stillbirth is something normal. And according to human nature, losing a life is not supposed to be normal. But because of the continued character that we have seen maybe before and even after, we have made it to become normal. And it is really, really draining us socially. You find when midwives are aged, they can explain to you whatever that they go through. But during your youthful life, you never get the impact of it until when it is your time now to go and rest. When you start flashing back to whatever that happened, can you write down the number of stillbirths that you had? Can you remember the names of the mothers that you had a stillbirth with and talked to them? We never have that opportunity. So that is a very nice initiative Madam Odessa is taking us through. And I think it should be started early when people are still students in colleges, so that they can be told it is okay to cry. It is okay to walk an emotional journey when you feel that you cannot handle it. So thank you very much, Madam Odessa, and we look forward to learning more from you. Thank you very much.
You're welcome.
Thank you, Del Queen. That's so sweet, and a lovely tribute to Odessa, who is amazing.
Thank you.
That's lovely to hear that you're so much appreciated, Odessa. And I'm sure there are many other nurses out there who feel exactly the same as Edel Queen. So we are over time. So unless there are any more burning comments, I think we probably need to close and let people get on with their next meetings and the rest of their days. But I would just want to thank you so much, Odessa. It was a fantastic presentation. Obviously very highly appreciated. I'm sure there are going to be lots more watches on YouTube once it goes up. Judith's on leave this week, but she'll be back next week and we'll put it up. But thank you so much. Thank you to all of you for being here and for listening and for contributing your stories. And let's all work together to at least reduce the preventable stillbirths. We can't never reduce them all or prevent them all, but we can prevent a lot of them by improving our care and our health system. So we all work towards that. So thank you, all of you, and a special thank you to COIN and members of COIN here who have very generously promoted this and also sent Odessa our way. We're so grateful to Karen and colleagues, Carol. So thank you so much. We're very happy to share her. Great. Everyone have a great rest of your day. And thanks again, Odessa.
Thank you. Thank you all for your time.